Hey, it's Daryl Baskin here again with San Antonio Ophthalmology Course 2025. This is the section on retinal vascular disease associated with cardiovascular disease. Here we go. Uh, just so you know, I mentioned Bernie a few times. This is a very common pathology that we saw there. You see the little rings around this patient's eyes. I'm going to highlight them with a pointer, but I don't think that's visible on the video. Those are Horner-Trantis dots due to limbal vernal keratoconjunctivitis. Really bad allergies, basically. And we saw this all the time. And unfortunately, they start to lose limbal stem cells. And then instead of just getting like a pseudogerontoxin, they get this terrible conjunctivalization of the cornea. And you get this. It's terrible. Really, awful stuff. So maybe someday that could be cured. We would treat it. Sometimes if we caught it early, we could treat it pretty well. We use a lot of tacrolimus and other things. Cyclosporin sometimes as well. So hypertensive retinopathy, let's talk about that for a moment. There's this talk of something called a FIPT, focal intraretinal periarteriolar transudate. So you can see these little yellow dots. Those are what we're calling FIPS. I have to say, I don't remember seeing these in the past, but anyway, they're supposedly different than cotton wool spots. So there you have it. There we go. FIPS cotton wool spot. Okay. The modified Shea classification of hypertensive retinopathy is as follows. Grade 0, no changes. Barely detectable arterial narrowing in grade 1. Grade 2 is obvious. Grade 3 is grade 2 plus retinal hemorrhages and or exudates. Grade 4 is a more obvious one. You start to get optic nerve head swelling. And then hypertensive choroidopathy typically occurs in young patients with severe acute hypertension, often associated with preeclampsia, eclampsia, pheochromocytoma. I had a patient with this in New Mexico a few months ago, renal hypertension. I saw her after she was getting better, thankfully. FA shows these focal choroidal hypoperfusion. These little dots. Oh, finally, another question. So what's the name for these areas of choroidal non-perfusion that appear as small tan patches that become pigmented over time with a halo of hypopigmentation? These are called Elschnig spots. And then there's a name for these linear pigment that's seen along choroidal arteries. Those are called Segrist streaks. You can get focal RPE detachments, bilateral exudative retinal detachments. This is a patient I saw a few years ago. Again, these flame-shaped hemorrhages, blurring into optic nerve head margin, florid optic nerve head edema with secondary retinal venous stasis, macular exudates. Essentially, it's one of the causes of neuroretinitis. Neuroretinitis is an interesting term. Some books like to limit it to infectious causes, but I like to think of it as a clinical picture of optic disc edema with essentially macular exudates or macular edema. You don't have to have the star, and you don't get the star acutely anyway. It's usually more of a subacute thing. So let's think about other causes of neuroretinitis. Here's a patient I saw a few months ago at UT. You can see in the OCT, he's got some hyperreflective foci within the inner retina. He's got a little bit of subretinal fluid. He's got some optic disc edema. And now on the fundus autofluorescence, you could see he definitely has something going on, and I was hiding it on the color fundus photo, but he had toxoplasmosis, actually without adjacent hyperpigmented scar. So there you have it. There's a lot of causes of neuroretinitis. I did make up a differential that's really kind of off the deep end, but I actually do use it. A lot of these mnemonics I make up and never use. This is one I like. So bear with me. Bart the idiotic dude threw a double tox salmon at the hull of the SS tuber in New Delhi. I use SS tuber in another of my mnemonics for intermediate uveitis, and it stands for the same thing. So let's go through it. Bartonella, idiotic, recurrent idiopathic neuroretinitis. Dude is Duzen. Double tox means not just regular tox like toxoplasmosis, but also toxocariasis, salmonella. Hull is herpes simplex, varicella, leptospirosis. That's the person who goes swimming with rat urine or something like that. Lyme disease. And then SS tuber. This stands in all my mnemonics. SS tuber means sarcoid syphilis TB. And then Nudali is a little bit less of the infectious stuff. The new just means, remember, this is a neuroretinitis differential if you missed that somewhere else. So diabetes, AION, that could be arteritic or non-arteritic. Hypertensive, or like an acute systemic hypertensive episode like we've been talking about, or leukemic infiltration of the optic nerve, and finally, idiopathic intracranial hypertension. So depending on your clinical practice, this may be a useful mnemonic, maybe just for testing purposes. At one point, I think I memorized these in alphabetical order, but that wore off after a while. So retinal vein occlusion, Talk about that for a moment. Here's a clinical presentation. This is the same patient I showed you earlier, just per autofluorescence, because I think the autofluorescence highlights the hemorrhages quite well. Classic findings: dilated tortuous retinal vessels, intraretinal hemorrhages. BRVOs are most often seen in superior quadrant. Those are the ones that are also most likely to cause symptoms, I think, as well. And we have a little bit of a bias based on the presentation. Cottonwool spots, optic nerve head edema, seen in more severe cases. Varying degrees of edema, ischemia, and hemorrhage. There's a lot of risk factors. I'll let you look at them there. None of them are surprising. Cigarette smoking, woo. RVOs should have a medical evaluation. In the absence of cardiovascular disease, a search for predisposing conditions should be sought, especially if the patient's under 50, like myself. Systemic anticoagulation is not recommended. There's a lot of studies looking at pharmacologic management of RVOs. This is just pictures I took. We'll hit some of the highlights here. Basically, anti-VEGF is better than either sham or laser. And then score 2, bevacizumab is non-inferior to aflibercept, but then Levo showed it was not non-inferior to ranibizumab, which is kind of confusing. Also remember, sometimes the BCSC book is written by people that have a lot of disclosures. They are consultants and receive fees, and no offense to any of them. Well, maybe this is offensive, but the more you get paid by somebody, the more you are influenced, and the more likely you are to influence others. Okay, sorry. Get off my soapbox. In eyes on anti-VEGF therapy, no added benefit of macular grid, laser, and BRVO. Just a few more findings. The original SCORE trial was mostly about steroid, and essentially steroid was comparable to macular grid for BRVO, and the CRVOs, it improved visual acuity versus observation, and of course cataract glaucoma. Dexamethasone versus sham for RVO was Geneva, and the best BCVA was best at 60 days out. And then essentially intravitreal, we already know this, the steroids increase, and I usually quote 35%, but in some patients they won't get an elevation of their eye pressure until like 2 years into treatment. And then ranibizumab is superior to dexamethasone according to this study, Comrade C, which I haven't read. Okay, so BRVO, a few key points. When the occlusion doesn't occur at an AV crossing, other inflammatory and infectious causes should be considered. And unfortunately, I might have missed one of these because this is not something I think about often enough. It's not always obvious where the occlusion is. And if it seems like you're getting multiples, you should definitely be looking around. And if they're not occurring at AV crossings, if you're more meticulous than I am, then hopefully please investigate that further. So BVOS defined ischemic BRVOs as having at least 5 disc areas of ischemia. They had a 36% risk of NV, and then untreated ischemic BRVOs had a 60 to 90% risk of vitreous hemorrhage. Vision loss may be multifactorial, lots of stuff. And I've seen TRDs from this. I usually see them when I work in Africa. A few more key points. Should be treated with anti-VEGF. There's no additional role for macular grid laser if they have macular edema. If they do develop NV, you should perform scatter laser photocoagulation. Don't just keep them on anti-VEGF. So CRVO, some patients may actually get transient visual obscuration prior to the appearance of their retinal findings. Just keep that in mind. And CVOS defined an ischemic CRVO as having at least 10 disc areas of ischemia, but that's on standard 7-field photography. So if you get an Optos wide field FA, you're now going to see way more than 10 disc areas of ischemia. So a little bit of an artifact holdover from the old days. And they can look like hyperviscosity or ocular ischemic syndrome. So what's the risk of NVA in an untreated ischemic CRVO eye? 60%. How long after CRVO begins does NVI or NVA present on average? It's about somewhere between 2 weeks to 6 months. Okay, we're going to contrast that with CRAO soon. CRVOs, you should perform gonioscopy at presentation and follow-up appointments. If you're given anti-VEGF, probably not as necessary. In the absence of treatment, these patients should be monitored monthly for the first 6 months. PRP should be performed at the first sign of NVI. And then what's the risk of conversion from non-ischemic to ischemic by 3-year mark? This is important to know because you think they're going to do fine, and then a third of them are going to get worse. I've had this happen. I've had somebody who's just mildly non-ischemic, or he was non-ischemic. I did a sectoral PRP in a few areas just based on his FA. And then, a few months later, all of a sudden he's even more non-perfuse, and I had to add more PRP in and he had NV. So ocular ischemic syndrome, you don't usually get the tortuosity, but you get the dilation as compared with CRVO. Usually there's ipsilateral carotid obstruction or ophthalmic artery obstruction, gradual vision loss, weeks to months, aching pain is not uncommon, prolonged recovery of vision after bright light exposure, like photostress. Usually they're over 55, 20% of them are bilateral. These are usually vasculopathic patients, unfortunately. MVI in 2/3, AC cell in 20%, narrow arteries, dilated, as I mentioned before, non-tortuous veins, retinal heme, usually larger, mid-peripheral. IOP may be anything. Ophthalmodynamometry may help differentiate OIS from CRVO. OIS has lower perfusion pressure. It's easier to stop that. And then fluorescein angiography. There's these key findings: delayed choroidal filling, prolonged AV time, and prolonged or prominent vascular staining. Which of these FA findings is the most sensitive? You'd think it would be delayed choroidal filling, which is that arm to retin time, but actually the prolonged AV transit time is a more sensitive finding. ERG, I don't know who's doing ERG for these, but decreased amplitude, both A and B waves. Maybe I should be. Okay. This is a slightly harder one to diagnose. I send a lot of folks for ultrasound, carotid ultrasound, and not very many come back with ocular ischemia or come back with carotid artery disease that requires endarterectomy. Usually caused by a greater than 90% carotid stenosis. Eisenmenger syndrome, which is like pulmonary hypertension, carotid artery dissection, that would be a scary one. Giant cell arteritis, other inflammatory conditions. Okay, when you give these talks, you start thinking, man, who have I missed? 5-year mortality is pretty high. It's almost 50%. And then the most definitive treatment is carotid endarterectomy or stent. I had one patient with something called an ECIC bypass. That was a long time ago. It's high morbidity with all these procedures. Reperfusion may lead to marked ocular hypertension. I got to watch out for that. And NV should be treated PRP. Cotton wool spots. Let's talk about these for a moment. Infarction of NFL leads to the appearance of cotton wool spots. Here's the thing. This is the testable part, the last bullet. If even one cotton wool spot is found in an otherwise healthy individual, workup should be done. Because sometimes you find out the patient has leukemia or collagen vascular disease. Obviously, you're not going to find out that they have radiation retinopathy if they've never been radiated. But it's important. And the other thing is this patient ended up having GCA, the one who's had one cotton wool spot. She came in with some really bizarre visual complaints. Everything was too bright. Okay, so a little bit like an ocular ischemic syndrome. BRAO, so this is branch retinal artery occlusion. You can get a cholesterol embolus from the carotid artery, platelet fibrin embolus, calcific embolus from cardiac valves. And then rarely, and that's what they like to test on, fat emboli from long bone fractures, septic emboli from endocarditis, and talc and IV drug abuse. And then migraine can actually cause a BRAO, believe it or not. There's a lot of causes listed here in the book. They did not include GCA, which I think they should have. And the management, well, we don't really have much we could do, except we do refer to a stroke center for looking for CVA. And then we'll also get, cardiac valvular disease evaluated with like a TTE, typically not a TEE. And then I'll also do a carotid ultrasound. And I'll do those things non-urgently if they come in after it's been there for, a few weeks or a few months. I'll say a few months. And it's usually they don't have this presentation on their fundus exam. They're just going to have a thin inner retina that's in this kind of geographic distribution on the on-FOSS image of their OCT, and when you look at the thickness profile. No specific therapy. CRAO, there's that island detachment again. Sudden complete painless loss of vision. Retinal edema renders normally transparent retina opaque. That's where you get the cherry red spot because the center of the retina does not have the inner retina present. And then the causes of the CRAOs overlap with that of BRAO. So what's the NVI, NVA risk in CRAO eyes? We talked about it earlier for CRVO eyes. In these eyes, it's lower. I say 20%, it's 18%. And then how long after CRAO does it happen? So we said with CRVO is like 2 weeks to 6 months. With these guys, it's usually about 4 weeks. So it's on average sooner. So I'll have these patients come back and check them for NVI a few times before I let them go. This is that same patient I showed you earlier with the single cotton wool spot, ended up having GCA. She has choroidal partial perfusion. I don't know why I'm showing it on the CRAO picture, but I'm showing it because, when the embolus is not seen, a thorough evaluation for GCA must be initiated. This is not a CRAO patient, though, so just to be clear. Lab evaluation includes ESR-CRP, fibrinogen level, CBC. It's high enough, start the steroids, get the TA biopsy. And now this is a patient with a CRAO. Most important thing to do, identify underlying systemic etiology, urgent referral to stroke center, risk of MI is elevated. 78% of RAO patients have undiagnosed risk factors, and they should have a diffusion-weighted MRI brain. 31% of them will have small cerebral infarctions. So there's no level 1 data to support any treatment for CRAO. AHA actually does recommend intravenous TPA if they come in within 4.5 hours, and intraarterial via ophthalmic artery for those who are evaluated within 6 hours and aren't candidates for TPA intravenously. I haven't ever worked at a place where this was going on with the intraarterial TPA. And PRP should be given if NVI appears, of course. Interesting, cilioretinal artery occlusions, not very common. About 25% of people or so have cilioretinal arteries. Usually they happen in the context of a CRVO, but if you see a cilioretinal artery occlusion in isolation, you should think about GCA. Ophthalmic artery occlusion, which I have not yet seen, very rare, and there is no cherry red spot in these, although it kind of looks like there is one in this picture. I think this is a picture on the book, actually. And so 3 possible etiologies. Mucormycosis should always be thought about, an internal carotid artery dissection, and then embolization from like a cosmetic facial filler. We'll talk about PAM for a moment. Ischemia to which of the following capillary plexi is responsible for causing PAM? Is it A, B, or C? So I'm going to go back to this picture I showed you earlier. PAM's in the inner retina, which is the internuclear layer, so it's the deep vascular plexus. It's a deep vascular plexus. They usually have, if they present at all, I'm assuming a lot of people don't, they have a paracentral scotoma, diminished visual acuity. Acutely, the OCT shows hyperreflectivity in the INL, often associated with retinal vein occlusion. That was the first time I saw one in a patient where they had an underlying CRVO and he came with a new scotoma. So retinal arterial macroaneurysms, RAMs, ectasias that are acquired somewhere in the first 3 orders of the retinal arterioles. Large RAMs can traverse the entire thickness of the retina, and they may cause preretinal hemorrhage, subretinal hemorrhage, intraretinal hemorrhage, or macular edema, basically blood in any layer. And they will sclerose spontaneously, but laser can be used if vision's threatened. Just remember that laser can cause thrombosis and an RAO as well. So what percentage of RAMs are bilateral? It's low, it's 10%. And what percentage are in patients with hypertension? That's high, 2/3. And this pretty much wraps up our section. So thank you very much. And remember, always wear your eye pro. Bye-bye.